Let's talk a little bit about our transcatheter valve program. I want to start by just kind of recognizing the team that I work with. Neil is my co-partner in crime here. Neil and I have been at this from the very beginning. Neil is one of the best trialists in the world, and I've learned tremendously from Neil. Colin is my other IC partner with Manny Reyes, and our fellow Ankar Kalra has been a superb fellow working with us. He's come down here as a fellow. He's done over 100 TAVRs as an operating surgeon, which is, I don't think there's any other fellow in the country that can claim that. And then Mahesh Ramchandani and Ross Rule have been my two surgical partners in this. We did our first case in January of 2011. So what have we done since then? Well, we ran the Corevalve U.S. pivotal trial for extreme risk and high risk. I was fortunate to be on the executive committee of this, and we were actually the high enrollers for extreme risk, and we were the high enrollers for high risk. So we really helped launch this and bring this to the country. This was for the Corevalve, which was the self-expanding valve, and we did it by 3 routes, either femoral, subclavian, or direct aortic, and it came in 4 sizes back then. And what did we find? Well, what we found is in our extreme risk trial, which we could not randomize against medical therapy, since partner had done so well, it was no longer ethical, we actually went against an objective performance goal, a data point that we had to beat, and that data point was the 95th% lower survival of the partner B medical arm plus 5 contemporary BAV trials. And when you looked at that, that gave us a goal of 43% at 1 year and 58% at 2 years, and we beat that handily. And so this valve got approved by the FDA and got approved without even a panel. This got presented and just got approved right away, which shows you the strength of this data. And then we did the high risk. Again, we were the high enrollers in high risk. And interesting, when the 1-year data came out, that was presented by Dave Adams at ACC in 2015, I believe, 2014. And what we found is we actually had superior all-cause survival for TAVR over surgery. We'd never seen that before in a TAVR trial. In fact, we had never seen that in any interventional trial against surgery ever, that the interventional device could beat surgery for survival. And we did. Now, the trial was set up as a non-inferiority trial with a hierarchical pre-planned superiority test if we made non-inferiority. And because of that, we only needed a 1-tail alpha to show superiority. And that raised a lot of hackles because people said 1-tail alpha, we don't really believe that. Now, the FDA believes it, the Imaging Journal believed it when we published it, but there was a lot of controversy. So I got to present the 2-year data at ACC. And by 2 years, we weren't on the original plan anymore, so we did a standard 2-tail log rank, and we still made superiority. Again, this is really amazing that this transcatheter valve made superiority. And at 3 years, we'd lost superiority. As our numbers got smaller, but we still had a delta of 6.2% in favor of TAVR. Pretty interesting news, all-cause mortality or major stroke, which is what you really want for your patients. And again, this was actually superior at all time points. If you look at all stroke, one of the things that we saw when Partner did their first randomized trial against surgery, Partner A, was the survival was the same, but the stroke rate was twice in TAVR what it was for surgery. And everybody was concerned about that. And we came along with this trial and actually reversed that and had less strokes in TAVR than in surgery. And in fact, every trial since then has followed this pattern. And if you looked at major adverse cardiovascular and cerebral vascular events, superior for TAVR at all time points. And if we looked at the other endpoints that we see in all of our trials, this is really important to me because in every randomized trial we've seen, the surgery has more life-threatening bleeding and transfusions, more acute kidney injury, and more atrial fibrillation. Why is that important? Because these things kill you now and they kill you later. They have an ongoing hazard risk of death. And that's one thing that's going to be harder for us to eliminate from surgery as we go down the risk scale. And then TAVR had more major vascular complications, and for this valve, more pacemakers. Everybody got better. They felt better. Both these got rid of the aortic stenosis. You got feeling better. But surprisingly, TAVR had superior hemodynamics over surgical valves at every time point. These valves are tremendously good for flow. And in fact, one thing we found with the TAVR trials, we've helped show for our TAVR program, is that TAVR is really good for women. Why? If you're a woman, you have an independent risk factor for getting your aortic valve replaced, just by being a woman. Is that because women are weaker than men? No. It's because women are smaller than men. So they got small surgical valves with less good flow. Whereas these valves, even in the smaller sizes, have really good flows. So it's really interesting as we move into smaller patients, and many of our women are smaller, TAVR is an increasingly good option for them. Now, regurgitation is still a problem with TAVR, but something that we're working on and getting better. We did subgroup analysis. It didn't matter if you're big or little, older or younger, man or woman, good EF, bad EF, diabetes, no diabetes. TAVR was favored prior CAB, no prior CAB, PVD, hypertension, STS above or below 7. TAVR was favored in every single thing. In fact, we even looked at STS less than 7 to see if in the lower end, maybe surgery would do better, and TAVR still won. We even thought about, well, gee, are these valves kind of wearing out in time? So we said, let's look for a 50% increase in the mean gradient over time. Now that automatically favors this for surgery. Why? Because the surgery mean gradient was 12 and the TAVR mean gradient was 8. So for surgery to have a mean gradient increase of 50%, it has to go up by 6. TAVR has to go up by 4. But still, TAVR actually had less of this than surgery. So neither one of these is showing signs of structural deterioration. Now when we lost, we as a group were really kind of surprised. At least I was surprised as a surgeon. I expected to win. And so we said, why did we lose? And so what we did is I went back and I looked at every death in the TAVR arm and every death in the surgical arm. Caught all the records, read all the deaths, and I put to paper why they died and when they died. So this curve is an instantaneous hazard risk of death. Not surprising, on day 1 you have a pretty high risk because that's when your procedure is going on. Then it falls pretty rapidly day 30. Now what's changed is this yellow line for TAVR is falling way, way down. Why? Because the very first TAVR I did and the very first TAVR Neil did, we did in this trial. But the aortic valves that I did in this trial I'd already been doing for 25 or 30 years. And then it got to 30 days, and TAVR stayed low, and it actually stays low out to 3 years because I've tracked it to 3 years, but surgery goes up, and it comes down at 4 months, and then it tracks TAVR. Why does surgery go up in a month? In fact, if you look in the US and ask when people die after heart surgery, there's 2 peaks, day 6 and day 45. Why is that? Why do people die in these funny ways? Well, day 6, where the people are so sick, they're going to die no matter what we do. Day 45 are the people that are sick, but we can keep almost anybody alive for 30 days. And then send you to an LTAC. If you live 30 days and leave the hospital, you're no longer a surgical death. So everybody gets you to an LTAC, and what happened to these people in the LTAC? They just withered away. And that's what's happening when you see month 1 to month 4, is these are the surgical people that just couldn't go home. I also looked at where everybody went when they left, and most of the TAVR people went home, and 60% of the surgical people went to some sort of care facility. And that's why that was happening. And again, we've kind of helped show that, and it's a little bit of where we're going to go down. And so, you know, if you really want to think TAVR is better than surgery, it has to have better or equal mortality. It has that. Better or equal hemodynamics. It has that. Quality of life. I didn't show you the quality of life data, but it's really it's straightforward. We use what's called the Kansas City cardiomyopathy score. A 5-point increase is a small increase, 10 points moderate, 20 points large. They both go up 24 points. The only difference is TAVR goes up quickly, and surgery takes 6 months to get there. At 1 month, TAVR is superior to surgery for quality of life. By 6 months, they're all the same. Patient acceptance, again, I'm not going to provide you any data. You know, Neil will tell you everybody comes into our office wants a TAVR. You know, they walk in and say, Dr. Reardon, I've read on the internet, I want a TAVR. And I say, sorry, but you got left main disease, you need a coronary bypass. No, I want a TAVR. I've read about it. It's better. Everybody wants a TAVR. Now, there are some morbidity issues that we're working on, and this place has played a big role in this in trying to get down paravalvular leak and pacemaker and durability. We don't know about durability, and we're not going to know about durability with these patients because these patients are 83 years old. And until we get to younger patients, we're just not going to know. We also ran the Corevalve expanded use trial. We looked at low flow, low gradient aortic stenosis. We looked at renal failure and dialysis. We looked at severe mitral valve regurgitation and tricuspid. I'm actually going to present that at the AATS this year. And we looked at valve and valve. And we helped get all of these things approved as part of the IFU. And these are other trials that we led here at the Methodist Hospital. So Jeff Popma presented this at ACC recently, and this is the Evolute. Evolute is the new version of Corevalve. The thing that's different about it is that the Corevalve, once you deployed it, was gone. The Evolute, we can deploy it to its 2/3, it's in position and working. We can look at it and decide if we like it. We can echo it, we can do arteriograms, we can do whatever we want. If we like it, we let it go. If we don't like it, we can actually pull it back up in the capsule and move it, put it in a new place, take it out, put it in a new valve. So it gives you the confidence to get it exactly where you want it. I always tell people it's like if I took a board that's 4 inches wide and it's 30 feet long, I'm going to make you walk across this board. If I put it on block 6 inches off the floor, you just scoot across there. No big deal. Because if you step off, you step back on. If I take that same board and put it in buildings 100 feet in the air, you're paralyzed. Board's no different. You're no different. The consequences are different. Having a second shot at things makes a difference. And at the Evolute, we found a couple things. One is our pacemaker rate went way down. It's a little over 13%, and the paravalvular leak rate went way down. Evolute 2.0 is the new version of this valve that we led. We were actually the lead enroller in this one too, and it now has a skirt on it to cut down paravalvular leak, and this will be presented at ACC this year. Reprise is the Boston Lotus valve. I'm fortunate to be the national PI on this trial along with Ted Feltman. And we've completed that trial, and it is going to be presented at EuroPCR this year and hopefully simultaneously published at the New England Journal of Medicine. It's an interesting valve because it too is nitinol and expands to a certain level, but it has a buckle and a post at the top and the bottom connected by a wire. As you turn the handle, these things come together until they lock like a seatbelt. As you shorten something, what happens to it? It widens out. And so we can dial this valve in slowly. It's never obstructive. We can go as slow as we want. We get it all the way in position and locked, and then we look at it and decide if we like it. If we like it, we let it go. If we don't like it, we don't lock it. We can move it. We can take it out and put a new valve in. So we're now getting valves that you should know exactly what you're going to get before you let them go every single time, much like a surgical valve. So this is going to be presented at EuroPCR. Reprise 4 is going to be, that was for high risk. Reprise 4 will be for intermediate risk. I'm fortunate to be the national PI on this with Raj Makar, and we will be starting that somewhere in the next couple months. This is already in front of the FDA. It's already been approved by the FDA. And we're really waiting for a new delivery system called the Edge delivery system. And Reprise 5 will be a low risk. We can't do the low risk because we're in the Medtronic low risk trial. I'm the national PI on that. And so we're only allowed to do one at a time. The low risk will be run by Ted Feltman and Tommy Walter from Germany. Corevalve. Corevalve was the intermediate risk. I'm the national PI with Jeff Popman. It was a randomized trial between surgery and TAVR for intermediate risk patients, stratified by the need for revascularization. And we're going to present this data at ACC this year, so we're really excited about that. It's been submitted for simultaneous publication, and I'm hoping to hear by the end of the week, so we're going to know soon. And there are two low-risk trials. There's an Edwards trial, Partner 3, and there's the Medtronic low-risk trial. They're slightly different. Partners run by Marty Leon and Michael Mack, and then the low-risk trial for Corevalve is myself and Jeff Popman as the national PIs. And we're actively enrolling. This is going to be the last randomized trial of surgery that we're ever going to see. And so it's crucially important that both these trials get completed. And I would urge all my fellow surgeons here that if you see somebody that's low risk, let us consider them for the trial. Right now, nobody wants to do that because these are low risk and surgeons want to operate on them. So when we started high risk, asking surgeons to give up those cases, that wasn't so hard. That's like maybe giving up a call day or something to them. You get the intermediate risk and now you want to borrow their car. You get the low risk, you're like asking to sleep with their wife or something. And nobody wants to give up low risk. I mean, it gets really tough, but it's really important for us to kind of get this done. Now, why is that important? Because we look at the high risk, that was 6.2% of our population, FDA approved. Intermediate risk, which has been approved for the balloon expandable, and we'll see after Surtavi, is about 14%. But the low risk, that's 80% of the cases. That's going to fundamentally change what we do. And this is what's happened to our valve clinic. We started a valve clinic because we got passed over for a partner. Neil and I said, listen, we can't be passed over. We got to organize. We got to have a valve clinic. And we now see over 100 patients a month in valve clinic. This is what's happened to our TAVR volume. This is what's happened to our surgical volume. Initially went up, but it's starting to drift down. But the good news, if you add them together, as an institution, as a cardiovascular group, we're doing better. And much like vascular surgeons figured out when EVAR came along that they didn't know how to do that, they were going to lose their field, cardiac surgeons need to be looking at this going, if we don't learn how to do TAVR, we're going to lose much of our field. This is a great team sport. Now, I'm going to go through this real quick. We're also part of the early feasibility trial for the Medtronic Intrepid Transcatheter Mitral Valve. We've done 4 of these now. It is a nitinol frame with a 27 valve inside of it. There's 3 different frame sizes, but only 1 valve size. It seals in there very nicely. I'm going to go pretty quickly because I want to get Colin up here. Right now it's transapical. And that's a problem because a lot of these are FMR patients with big, thinned out, dilated ventricles. By the end of 2017, we're going to have a transvenous transseptal version of this, which I think is going to fundamentally change the way we look at some of our FMR patients when we don't have to poke a hole in their heart. If you've already got an EF of 30%, I put a valve in you and I knock it down to 20, and I knock off another 5 for the hole of the apex, that's really not a good thing. So just to show one of the ones, we had a 74-year-old man. He had severe functional mitral regurgitation. He'd been on milrinone in the hospital, functional class 4. We were having trouble keeping him out of the hospital, fairly high STS, 8.5. This is his echo. This is our planning. We actually do a CT scan, and we actually insert these valves in there on the CT, and we calculate the neo-LVOT, because one of the problems is these valves are fairly big. Paul Graber, a good friend of mine, an echo guy in Dallas, describes it as sticking a beer can in the mitral annulus. It's not quite that bad, but obstructing the left ventricular outflow tract is important, so we actually calculate by putting one of these in digitally what our neo-LVOT is going to be in diastole and systole at the different parts of the valve. This is our planning. We go through a pretty extensive planning. We want an angle of at least 120 because then it opens it up and less chance of LVOT. We actually plan where we're going to make our skin incision because it's all different depending on your shape of your sternum. And so this is, we've made a little tiny anterior thoracotomy, and we're trying to figure out what we're going to do. And this is a picture of me poking my finger into the apex, asking Steve Little, does this look like a good spot? And we're just poking and poking and poking. And once we find a good spot, then I put a little purple mark on it, and that's where we're going to go in. Very high tech. Only heart surgeons can do this. Colin wanted to do it, but I said, no, Colin. This finger is trained for years. And so we take this and we put in these concentric pledgeted sutures. And then we put the sheath in there. Now, the sheath is a pretty big sheath. It's about 32 French. That's a big sheath, and it kind of screws into the ventricle so it doesn't leak. And you can see this rigid thing coming in. This is the rigid thing going in. Interesting enough, in this particular one, I was in position 1 putting this in. Colin's done position 1. Ross has done position 1. But all this is done by echo. This is not fluoro at all. This is all by echo, and Steve is sitting there, and Steve is telling me anterior, posterior, medial, lateral as I guide this thing through. So as a surgeon, this is actually kind of a new thing for me. Took us 48 seconds to cross. We got to switch into a 3D mode. Now you can see we're looking at it coming in towards us in the atrium. And when you see it moving back and forth, this is actually us practicing so that we get our teamwork down. And so we'll get it in there, and we go to 3D, and Steve will go anterior, posterior, medial, lateral. And what I'm trying to do is move as he says that and wire this into my brain. What is the medial move? What's the lateral move? Anterior, posterior is pretty easy because if you're on a fulcrum, you want to go anterior, you move it back. But medial lateral is a little more confusing. And so we do this for a little bit so that the team kind of gets the feel down, kind of rewires your neurons. Now at the same time, this is the first one we're doing, I'm putting it in. Neil's watching this on fluoro as it comes across. And once we have it in position, Neil's now cranking this out, and he's extruding the valve until the flange comes out. At this point, it's not obstructive. You're not pacing. Patient's very stable. And we're just going to take the flange out. And again, there's no reason to rush any of this. And once the flange comes out, now we're looking at an echo, and you can see the little flanges above the mitral valve here. And again, we're practicing with Steve going anterior, posterior, medial, lateral, getting this thing centered on the annulus. And again, we now look at it in 3D again, and we want to make sure that it's completely unfoiled. If there's any kinks in it, any bends in the flange, I want to put them someplace where it's not going to bother me, which is usually at the commissures. And so we rotate this, so it doesn't matter which way the valve is oriented until we get it where we want it. So now what we do is we do a rapid pacing run, and we mark the annulus, and we want this thing to touch down 6 millimeters above the annulus. So Steve is drawing a line now. And he's going to go draw a parallel line that's 6 millimeters above. And then I'm going to fix in my head, and Steve's going to fix in his head where these 2 dots are. Because once we do this, the next pacing run is we're going to try to bring it back down. And once we get it into place, we're going to deploy this thing. And one of the things that we try to do when we do this is we want to make sure that when we're ready to deploy, everybody's happy. So when we get ready to deploy, there's 3 people. There's an engineer there from Medtronic. There's Steve and myself, and I need 2 goes or no-goes from these guys. No, nothing equivocal, either yes or no. There can't be any maybes. A maybe is a no in this. So now we align the brim, and we're getting ready to rapid pace here, and you can see it's above there, and I'm going to start pulling it down into position once we start pacing. I'm just trying to get close here before we actually start. You can see we're slowly moving in on where those spots would be. Sorry, it's a little longer than it should have been. And then once we did that, we go into rapid pacing. And in this particular one, when we were rapid pacing, I couldn't quite get where I was. I couldn't get 2 goes. So what do you do if you can't get 2 goes quickly? You turn off the pacer and you push it back in the left atrium and you line up again. What you don't want to do is fiddle around too long. Again, this is the very first one we're trying. I'm a little nervous about it. Steve's a little nervous about it. This is the only time we've ever had to go back in the atrium. Every other time it's just been really easy and it's gone right in. So that was 20 seconds of pacing. Didn't really do the patient any harm. So now we're going to go back at it again. We're going to line it up. Once we get lined up, we're going to start pacing again. The whole pacing run for this is 22 seconds before it's deployed. You can see I'm trying to get it right down into line. You can see the brim starting to fold up. Now we're pacing. Now I'm slowly pulling it in. You can see it coming in, you see it coming in. And then what's going to happen is I'm going to get a go right here. And once I get a go, you'll see the valve start to come out. You can see the valve being deployed. Now the valve is still held right here, and we can pull it out, but we can't do much else. At that point, we say, well, we still go. If it's still a go, we let go of the valve. Now while we're doing this, this is what Neil's looking at, because I'm looking at the echo, not looking at fluoro at all. Neil's looking at fluoro, not looking at the echo at all. And once we get 2 goes, then Neil starts to deploy the valve. So now we still have hold of the valve. We can adjust it a little bit. We want to know if it's really there. If it's really there, then say release, and now it's released. Now we have a functioning valve. Basically, we're done at this point. Now all we have to do is pull it out and close up the hole in the heart, which is not that big a deal. But here we are in a very good position. The apical access puncture to closure was 28 minutes. This doesn't take very long. The procedure, insertion to final deployment, 21 minutes. We had rapid pacing for 22 seconds. We have really good function, kind of trace valvular MR, but I don't think any of you would be too worried about that. We're still on heparin. There was no gradient. The gradient across the outflow tract, the mitral valve was 2. The outflow tract was 4. We have very good sealing. This is the ventriculogram. You can see it's nice and round. No LVOT gradient. You can see the outflow tract's really nice and wide open. Again, the valve function of the mitral is very good. You can see how it sits in the atrial side. And then here's the pre and post from Steve's 3D. Really very impressive. He comes in follow-up 1 month later, still looking good. And here he is in clinic. This is a man who had been on milrinone, couldn't do anything. He's back to normal activity right now. So I think, we're doing some really exciting things in the replacement field, and I'm going to turn it over to Colin, because Colin's going to talk a little bit about what we're doing now in the transcatheter field, not replacement, because there's some really exciting things happening there too.
So I'm going to show you what we're able to do beyond repairing A2P2 flails, which is the indication and the way the mitral clip has been studied and approved, and we've taken it beyond that quite a bit. We have the largest experience in the world for fixing mitral valves after they've had a previous repair. Last time I spoke to you guys, I showed you a pig that we had put a mitral clip in the tricuspid position, and now we've taken that and done it in some people, and I'll show you that, and we were one of the first in the world to do that as well. And we're going to move on now into new devices for tricuspid valve repair, which I'll quickly touch on at the end. So I think you're now very familiar with this system. It's a 24 French transvenous transeptal device that is designed and approved really to form this double orifice in the A2P2 position. So here's one of the non-A2P2 position cases we did. Typical elderly gentleman, lots of comorbidities, severe mitral regurgitation, heart failure, STS score of 7.8. After being evaluated by the heart team, was deemed a good candidate for a transcatheter mitral valve. So let me get the mouse so I can point some things out here. So here's our 3D on phos view, and usually our target is right here. Here's the aortic valve anteriorly, and usually it's an A2P2 prolapse. This gentleman had a commissural area that was prolapsing, and technically it can be very challenging for 2 reasons. One, the imaging is very difficult. Steve had to spend a lot of time and effort in figuring out a way to really properly visualize this so that I could guide the catheter and the clip into position. So it's really a 2-man job. I mean, he's the eyes and I'm the hands, and without either one of us, none of this could be done. So after some work, he figured out a way of sort of obliquely visualizing the defect so that we could guide the catheter down in order to repair the leak. And so here we're coming transeptal with our usual catheter. So here we are lining up the device. And again, usually we'd have the device lined up at sort of 12 and 6, but here you can see we're very tilted and also very medial. We had to come right down the septum. in order to get into this defect. The other concern, and the reason people have avoided doing these off A2P2 position clips, is that once we're below the valve, there's a risk of disrupting the cords, cutting the cords, and creating somewhat of a disaster. So in order to overcome that, we actually cross in the closed position, and then we're able to line up, which is more like sort of an arrowhead, and we're able to line up the device in a closed position through some visualization techniques Steve has come up with. And so here you can see we're in position, we've grasped the defect, we haven't created a diastolic gradient, we've reduced the mitral regurgitation, and therefore released it. And upon release, we've significantly improved not only the mitral regurgitation, but also the physiology. The left atrial pressure dropped, the V wave went down to essentially nothing, and the MR went from severe to 1+. And here's the sort of dramatic picture. Usually when you see a post-mitral clip, it's really a double orifice, sort of dog bone picture. But here it's a single orifice, and we've eliminated that commissural flail and essentially returned it to a relatively normal appearing mitral valve. So this is exciting. This is one of a handful of cases we've done, really dependent on Steve's ability to visualize these non-A2P2 defects, and are sort of willing to take some risk and try to do this without disrupting the mitral valve too much, and think that in the future we'll have some alternatives as far as treating a broader population with mitral valve disease. The next group that we have, as I mentioned, the largest experience with are people who have had prior mitral valve surgery and then have degeneration or recurrence of disease and referred generally for a redo. And 90% of these are done outside of here and referred here, generally Dr. Laurie, to do a redo mitral valve repair on. But now that we've come up with this alternative, I'll show you sort of our experience. But here's an illustrative case. This is a gentleman who had a mitral valve repair a couple years ago and developed recurrence of disease, had some other comorbidities, wasn't exactly the most appealing reoperative candidate. And again, this requires some skill and technique and adjustments on Steve's part, in that imaging under these rings can be very difficult, and sometimes he'll have to be creative and he'll go sort of transgastric, and we'll have to image from the ventricle up, which is, we have to sort of completely flip our communication when we're talking anterior, posterior, medial, lateral, as Mike was describing. But we've done this now several times fairly successfully, and essentially eliminated the MR. And this is this guy at 18 months, doing well, still with no mitral regurgitation. So here is the work that Eleonora has put together that she's getting ready to present. And so we know that despite surgical repair, a lot of these patients who have mitral valve disease will recur. Reops do come with significant mortality and morbidity. And the clip seems to be a potentially appealing strategy. The first report of anyone doing this was in 2010, which were 2 cases of severe MR after valvuloplasty. So one patient, when we put the clip in, he did develop severe mitral stenosis, so we aborted, but without any harm. We were able to take this out without hurting him. Not to go through this in great detail, but your usual elderly people who were symptomatic with severe disease and had multiple comorbidities. No difference in procedural time when we compared those treated with the native valve versus those who had a prior ring. The entire procedure takes about an hour with 15 minutes of fluoro time and 30 minutes to put a clip in and get out. One of the concerns was we would develop significant mitral stenosis or diastolic gradients, but that in fact did not happen. When you look at the patients who had a prior ring, the average post-clip gradient was 4 millimeters of mercury, so not significant. It's something we tolerate. Generally, we tolerate less than or equal to 6 millimeters of mercury as a closing gradient before we release the clip. And then invasive hemodynamics, again, showed significant improvement compatible in the ring patients, compatible with those who had native valve degeneration. Large V waves came down, mean left atrial pressures were reduced. The change in the V waves and the change in the mean left atrial pressures were compatible. The mitral regurgitation improved significantly, as you would expect, compared to those who had native valve leaflet disease. Most of them, 10 out of 12, left the lab with either trace to mild mitral regurgitation. At follow-up, most of them were symptomatic, either NYH 3 or 4, and at follow-up, all are much improved symptomatically at either NYH 1 or 2. So really, there's been no difference in procedural time when we compared this to native valve treatments. We did not have any issues with diastolic transvalvular gradients. There was no difference in the number of clips, and the outcomes at 30 days are comparable. So that's exciting, and Eleanor is getting ready to present that. So beyond the mitral valve, we've gotten interested in the tricuspid valve for several reasons. One is it's a difficult lesion to treat surgically. These patients usually have a lot of comorbidities, and there's been no available device. There are some unique features of the tricuspid valve that make it a little bit more challenging from our standpoint. It's oval shaped, it's large, it's much larger than the mitral valve, and it's not planar. It does become more round as it gets dilated, and most of these people do have a functional component. There's a whole spectrum of people trying things to treat tricuspid valve disease. From repairs, replacements, sort of secondary things by wrapping the heart and trying to manipulate the annulus, to some, this tri-cinch basically tethers the leaflet and then puts a stent in the inferior vena cava and pulls everything down to try to adjust the annulus. We've done this, and I'll show you our case, and we're going to get into this tri-line, which I'll show you before we close. So here's the case we did. We actually did a 3D print model beforehand and played around with it a little bit in the lab before taking the patient to the procedure to try to figure out where and how to fix this. Here's our case, and this is in the European Heart Journal, and Eleanor wrote this up. But it was a 77-year-old gentleman who had refractory tricuspid regurgitation with secondary cirrhosis, was almost 60 pounds overweight of volume. We were able, here's the baseline up here in 3D, 2D, and Doppler showing severe functional tricuspid regurgitation. We clipped the septal and posterior leaflet successfully and reduced the tricuspid regurgitation. And in the next 2 weeks, he was in the hospital. He suddenly began diuresing, and he put out almost 35 liters of fluid in 2 weeks. Now, he did well for about 3 months, and most recently he has recurred. So I think there will be an issue of durability. We'll probably, when we move on, we'll probably have to put more clips in, as people tend to tolerate this without developing much tricuspid stenosis. So we recently had our site qualification visit for the tri-line system, which is a percutaneous pledgeted system that bicuspidizes the tricuspid valve. So these pledgets are placed from the internal jugular vein. It takes 2 people, one to puncture, the other to snare, and you basically wrap these 2 pledgets. And in real time, you can cinch them and pull them together and evaluate how you've affected not only the tricuspid regurgitation, but also ensure that you haven't induced any tricuspid stenosis. So this is one of the first cases done in Europe, and so what you're seeing here are the 2 pledgets. The right coronary is wired up front for a risk of any right coronary occlusion. Here you can see the 2 pledgets are pulled together, and there's no issue with obstruction to the right coronary artery. And what you see on real-time echo is at baseline really no coaptation with severe mitral regurgitation, but after the valve has been bicuspidized by these percutaneous pledgets, you see nice coaptation and essentially mild at worst tricuspid regurgitation. Hemodynamically, the right atrial pressure went from 22 to 9, and the LV stroke volume went from 42 to 72 cc's. So really, I think something that could have a profound impact on some of these really sick people who otherwise don't have a good option when it comes to intervention for the tricuspid valve. So in closing, what have we done here as a team? And all of us in this room, I think, are part of this, and Steve, who's not here, is obviously our leader. We've shown that we can expand the use and effectiveness of the mitral clip beyond the A2P2 lesions. We've illustrated an effective therapy for recurrent and progressive mitral valve disease after repair. We have a larger series than all of Europe. We're one of the first to successfully treat tricuspid valve disease with a mitral clip. And given the groundwork that Mike and Steve have laid, or Mike and Neil, we plan to continue to lead in this field. Thank you.